Great. Good morning, everybody. I also would like to thank the organizers for inviting me to be part of this and especially to represent the American Academy of Pediatrics in this very important area of nutrition and health. So I'm going to start by talking a little bit about the approach that the American Academy of Pediatrics takes to statements. So the Academy has various kinds of statements that we develop and publish, and you can see them listed here. And I'll just talk briefly about each one to try to give you a sense of how they work, how they're developed, and how the evidence review goes with each of them. The clinical practice guidelines is the sort of highest level of evidence review, and because of the resources required to do this, there's a long, extensive approval process, and as you might imagine, there are fewer of these approved for going forward. But as you can see, that it consists of a formal evidence review and ultimately development of guidelines similar to the dietary guidelines you just heard about. This is a long and complicated slide, which I won't go through in detail, but you can see that there's a substantial methodology that allows us to go from the evidence and the review of the evidence to the actual guidelines. The next category is the policy document, policy statements, and you can see this drives the organization's activities or represents the organization's stance on a particular issue based on literature review, and ultimately should include recommendations that guide child health care and policy. The authorship is usually multiple committees or councils or sections, and the evidence-based is a level of review that is not quite as extensive, and the grading of evidence is not quite the same as the guidelines, but these are definitely evidence-based as they are constructed and uses formal rules of evidence and development. The clinical report is really just what it sounds like. It's based on literature review and data analysis and aims at helping the pediatrician make the best practice decisions based on current evidence. And again, the authorship is similar to the policy statement, and the approach to evidence is also similar to that used in the policy statement. And then there's a technical report, which really focuses on more technical issues underpinning either clinical decision-making or other types of issues related to pediatrics. This is based on, again, an evidence review, but this does not include recommendations. This is really designed to help pediatricians understand technical aspects underpinning certain topics. And again, the authorship is quite similar, and the approach to evidence is also similar to the other reports. So the intent process that is the first step in these, you can see is designed for kind of a bottom-up approach. So committees and councils develop these intents that are then reviewed and approved for going forward. And ultimately, once the intent is approved, there's a 2-year process of review, and that then leads to ultimately a draft, which is reviewed multiple times and revised, and then ultimately goes through a formal review process by the American Academy of Pediatrics leadership, and ultimately then is published in Pediatrics. And you can see that this talks about the executive review approach here and final approval. And then it's important to recognize that these are living documents. So there is a process ingrained that assures that these are reviewed at least every 3 years, and a decision is made to reaffirm, revise, or retire the statement based on new evidence. So let me talk about how this coalesces around an American Academy of Pediatrics set of thoughts about sugar-sweetened beverages and added sugar. And actually, the AAP has not adopted a formal definition of sugar-sweetened beverages. There is, and I'll talk a little bit more about this later, the AAP section on obesity and the Committee on Nutrition, in conjunction with the American Heart Association, is in the process of developing a policy statement on the health effects of added sugar. So this, unfortunately, is very early in the process, and we don't have a finished product to present. Many of you are aware that the American Heart Association recently published a statement on added sugars, and their definition was the definition used by the USDA, which is presented here. But I think it remains to be seen how the policy statement being developed by the AAP will define added sugars and sugar-sweetened beverages. So what about diet guidance? Clearly, this is an area of major focus by the American Academy of Pediatrics, and it really is throughout the child and adolescent lifespan, but the focus on the first 5 years of life is actually quite important and quite intense. And so there is a really very much an organized approach to help pediatricians, to help families make appropriate decisions about nutrition in this critical time period. I should also mention that in addition to policy statements and clinical practice guidelines, et cetera, there are 2 major publications that serve as the underpinning for nutrition guidance. And each of these are currently under revision. So there's the Nutrition, What Every Parent Needs to Know, and then what we often refer to as the Yellow Book, which is Pediatric Nutrition, edited by Ron Kleinman and Frank Greer. And this is an effort on the part of the Committee on Nutrition and others to create the overall view of nutrition guidance by the AAP. So what about sugar-sweetened beverages? Well, as I mentioned, the AAP does not have a specific statement on beverage intake in the 0 to 5 year age group. But having said that, there is a lot of focus on beverages and how they should be organized for this age group. And you've heard a little bit about some of these issues in the session earlier this morning. The AAP has guidance on feeding and nutrition generally for children age 0 to 5, and so I'll talk about that and how it relates to the topic for this morning. So in the first year of life, the recommendations are for exclusive breastfeeding for approximately 6 months and continued breastfeeding even with the introduction of complementary foods throughout the first year of life. And the only acceptable substitute for breast milk when breastfeeding is not possible for potentially a variety of reasons is infant formula. So think about drinks, nutrition in the first year of life. It really is focused on breast milk and infant formula. We'll talk about the introduction of complementary foods in a minute. But the fruit juice statement that was just published in Pediatrics now states that fruit juice, 100% fruit juice, should not be given in the first year of life. And that the complementary feedings, which would include baby cereals and other baby foods, can begin at 6 months of age and progress over the age 6 to 12 months. But the focus really should be on foods that are rich in iron, because there's a major concern about iron deficiency and iron deficiency anemia during that 6 to 12 to 18 month age range. In the second year of life, breastfeeding can certainly continue as a preference of the mother and child. This is when milk can be introduced. So no cow's milk in the first year of life. This is also, there's been some controversy about whether to use whole milk or lower fat milk, and the recommendation is more and more that lower fat milk can be introduced at age 12 months. And this also includes an emphasis on intakes of fruits and vegetables, beginning a lifelong pattern, hopefully, of intake of fruits and vegetables. And while whole fruit is preferred by far, 100% fruit juice can be given starting at age 12 months of life. And I'll talk more about that as we go along. But as we've already heard, there's a substantial focus on portion size for fruit juice, which I think is important, and also a focus on how fruit juice is delivered. So fruit juice should not be given in a bottle. It should not be given at bedtime, and this speaks to the issue of risk for dental caries, et cetera. And calorie-dense and nutrient-poor foods and beverages should be avoided, and we'll talk more about this in a minute. So in terms of introduction of complementary feeding, the concept is to choose foods that provide key nutrient needs and help meet energy needs at the same time. And I talked about iron. Zinc is also an important issue as complementary foods are introduced. The idea is to introduce a single food at a time, but ultimately to introduce a variety of foods. And by 8 months of age, all food groups should be represented. As I mentioned, no cow's milk during the first year of life, but as we head into the second year of life, low-fat milk can be considered. Limit consumption of fruit juice, no fruit juice in the first year of life, and ensure that homemade complementary foods are prepared in a safe, with a safe approach, and encourage the infant's involvement in the feeding process, really emphasizing the concept that also that foods need to be introduced and reintroduced, as Leanne talked about earlier this morning. And hopefully create a dynamic between the parent and the infant around hunger cues and satiety cues to support that concept of the infant and child knowing when they are hungry and when they're full. And then ultimately to monitor growth and development. And this is a key element in understanding whether nutrition is adequate or not. In the age 2 to 5 age range, this really is a transition phase to a more adult type of diet. And again, the emphasis is on low-fat milk. And I think the AAP would emphasize very strongly that milk should be the main drink in this age 1 to age 5 age range. But fruit juice is acceptable as part of thinking about an approach to encouraging fruits and vegetables, but only with the appropriate portion size. So I think if you think about fruit juice just from a caloric standpoint, there's no question that with excess intake of fruit juice, that can contribute to abnormal weight gain. So this is the reason for these portion size guidelines that you see here. 4 ounces per day from age 1 to 3, and then that can go to 6 ounces a day at age 4. And again, work to ensure that this is operative in the home, but also operative in other areas where kids get their nutrition. And again, emphasis on a diet rich in fruits, vegetables, whole grains, low-fat dairy, and lean meats as a way of creating this adult approach to diet. So during this age range, as I mentioned, pediatricians take the concept of growth and development very seriously, although I would argue we as pediatricians probably need to do better about noting changes in BMI percentile prior to the development of overweight or obesity. And I think if we're really going to be aggressive about prevention of obesity, which I think we need to do, this is something that pediatricians need to learn how to do better so that they can really track those children who are crossing percentiles in an upward direction. So there's substantial concern about the presence of fruit-flavored drinks, and we've heard about this morning. And I think the confusion between fruit-flavored drinks and 100% fruit juice is real and important to address. We know that sweetened beverages are one of the top 3 contributors to daily energy. We saw that earlier this morning. And we know that these can contribute a substantial amount of total energy. And we know that soft drinks are the main source of added sugar in the diet of young children. So these are all concerns as we think about risk of developing obesity. Soft drinks have been shown to replace milk in the diet. This is, again, a big concern because we know that the intake of vitamin D and calcium is critical, and soft drinks are displacing drinks that would contribute to better nutrition. And so essentially the AAP guidance is that soft drinks should not be given to children in this 0 to 5 age group. And that's also true of sports and energy drinks, inappropriate for young children. And that's important to recognize. Obviously, this is not being implemented in practice. We heard that this morning. So we need to figure out ways to make sure that the guidance here is followed. I mentioned the concern about obesity, and again, the health promotion efforts in pediatric practice should really aim at removing sugar-sweetened beverages from children's diets. And in the statement on prevention of obesity, we emphasize this very strongly. So what about some other issues? Some of these have come up in the course of the discussion this morning. So what about flavored milk? And I think while everyone would agree in concept that unflavored milk might be the beverage that would be selected and hoped for, it turns out that this may be an example where perfect is the enemy of good. It turns out that flavored milk may actually improve intake of milk in children. And there have been studies that have shown that removing flavored milk actually reduces the intake of milk, and that does not improve over time. So there's real concern that children, especially in the age group we're talking about, are not drinking enough milk, and that extends into the school age group. So at the moment, the AAP has accepted the concept that flavored milk can be part of a healthy diet. The AAP has not developed recommendations that differ for any subgroup in the population, but there is real recognition that cultural differences are important, and that may apply to how we implement different aspects of the nutrition guidance. So pediatricians certainly need to be tuned into the concerns and the issues of cultural competence, and use the knowledge about various cultural approaches to diet in a way of helping to steer families towards the healthiest diet possible. The AAP is also very concerned about the social determinants of nutrition. And we know that there are a variety of social factors that can impact good nutrition and lead to poorer nutrition. And unfortunately, we live in a world where we have simultaneously existing increased risk and increased prevalence of obesity and even severe obesity in our pediatric group with food insecurity. And so we need to be balanced in our thinking about how to overcome issues of food insecurity and lead to optimum nutrition. And I'll point out the policy statement on food insecurity, which was published last year. Just as Raphael talked about, the AAP is quite concerned about the role of media as it influences nutrition and nutritional choices. So I'll just go through some of the recommendations, and they go from pediatricians to families in terms of how to think about media. So pediatricians really should be starting the conversation early, asking parents about how they expose their child to media, and help families develop a plan around media use. And obviously this has to do with a variety of factors, exposure to advertising as we talked about, but also the balance of physical activity and other activities during the day. And it's important to educate parents about the impact of media on brain development, so that the parents can focus on approaches that actually improve cognitive development. And discouraging screen use for children younger than 18 months of age is very important. Pediatricians for parents of children 18 to 24 months of age should discourage use of screen media other than those that are interactive. And for parents of children 18 to 24 months of age who want to introduce digital media, advise that they use high-quality program, apps, etc. And children older than 2 years, limit media to 1 hour or less per day of high-quality program, and recommending a family approach to sharing media, and no screens during meals or 1 hour before bedtime as part of improving sleep hygiene. From a family standpoint, avoiding digital media use, as we talked about, turning off television and other devices when not in use, and keep bedrooms, meal times, and parent-child play times screen-free, so that this hopefully can promote a more family-focused approach to diet. And then obviously issues related to industry, making sure that industry is adhering to good practice in terms of media addressed at children. And this obviously applies to the kind of unethical advertising that Raphael mentioned, and especially points to the concept that children have difficulty distinguishing between advertising content and actual content, which is part of what I think makes this unethical. So AAP advocacy is informed by AAP policy, and as I mentioned, AAP policy is derived by expert committees, and that can include the American Academy of Pediatric Executive Committee as well. So the AAP is supportive of efforts to incentivize healthier eating. This is an area where we need more data, as we discussed earlier, and ways to improve access to fruits and vegetables and enhance consumer education. The AAP has not supported efforts to remove 100% fruit juice from WIC packages, and the AAP has not supported efforts to disallow certain foods and beverages, including sugar-sweetened beverages, from the SNAP program. And again, we can talk more about that as we go on this morning. The AAP is very much focused on the relationship of public policy to nutrition, and this is demonstrated by the very strong support for WIC and SNAP for the reasons we've been talking about this morning, support for the school meal program, policies that relate to availability of foods and drinks in schools outside of the school meal program, and other policies that relate to these issues we've been discussing, and all of which have an impact ultimately on the diet of kids. The AAP, as I mentioned, will be developing a policy, and this the title of the intent is Public Policy to Protect Children from the Health Effects of Added Sugar. So stay tuned for that as it is developed and ultimately published. The AAP does not have good data on the implementation of AAP nutrition policy by pediatricians and parents. This is an area we need to focus on. The AAP does have a periodic survey, which could be used for this purpose, but so far has not. So in summary, I think there are important gaps in evidence about optimum nutrition and the best way to support pediatricians and parents in the implementation of these recommendations. But there are general principles which we've been talking about that, if followed, would improve child nutrition and ultimately child health. It's imperative that we use evidence-based public policy to assist pediatricians, family physicians, dietitians, nurses, and parents in creating the healthiest diets possible for children in the U.S. The current USDA guidelines begin at age 2, as Raphael mentioned. We really need guidelines for the first 2 years of life, and I think the B to 24 initiative will help us as we move in that direction. So thank you very much, and I think we'll do a panel discussion next.